Hello everyone, this is Danny Bobrow, President of AIM Dental Marketing, welcoming you to this installment of the Practice Perfection Virtual Training Series. Today's very special presentation is provocatively entitled, Brushing Your Teeth May Be Hazardous to Your Health. But on a serious note, the Centers for Disease Control states that 50% of the population over 25 years old and 70% over 65 years of age has periodontal disease. Clearly, the traditional method of home oral care, toothbrushing and flossing, does not work. Periodontal disease, which, as we all know, is an inflammatory condition, is the most common and costly disease on earth. Systemic diseases associated with periodontal disease are very expensive, not only to treat through medication and hospitalization, but in terms of diminishing health, longevity, and patient productivity. Systemic diseases include those from cardiovascular disease, diabetes, breast and many other cancers, chronic kidney disease, Alzheimer's, and more. An ever-growing body of research points to the links between periodontal disease and systemic diseases and documents the costs and overall savings associated with treating it. 21st century science has revealed a more effective way for patients to arrest the buildup of oral biofilm. This new technology has undergone FDA approval and clinical research to show the dramatic improvement a new device offers as compared with use of a toothbrush. This improvement is graphically illustrated in the removal of biofilm and reduction of HbA1c and microbial and clinical parameters without the use of drug intervention or surgery. Inflammation is the fuse that lights the fire that robs us of our health and longevity. In today's presentation, you will learn how to extinguish the fire and, in so doing, extend your own life and that of your patients and team. Dr. Piero Policicchio, who, for obvious reasons, goes by Dr. Piero, is Dental Air Force inventor and CEO of Air Force, Inc. He graduated from the University of Detroit Mercy School of Dentistry and has practiced dentistry since 1982. His latest clinical trial studies in using Dental Air Force in conjunction with periodontal therapy compared to toothbrushing and flossing in diabetic patients showed a reduction in the diabetic blood marker, HbA1c, of over 1%, which may not sound significant, but, as you will soon learn, is huge in terms of reducing a patient's risk factors. Dr. Piero's published articles include those on periodontal health and its relationship with heart disease, respiratory health, diabetes, stroke, and other systemic diseases. He is the former executive editor of the prestigious Journal of Experimental Dental Science, a contributing author to Hospital Infection Control, Clinical Guidelines, and author of Never Brush Your Teeth Again. It is for these reasons and more that we are thrilled to at last have Dr. Piero grace the Practice Perfection stage today. Practice Perfection webcasts run for around 90 minutes. While attendees are in listen-only mode, we invite you at any time to submit your questions or comments using the question button on your screen. We will allow time following the presentation to get your questions answered. If we do not get to your question during the webcast, we'll see that they're answered shortly thereafter. Attendance at this presentation entitles you to receive 1.5 hours of continuing education credit. Shortly following the webcast, you will be emailed a brief survey with instructions on how to receive your CE. Participants are cautioned about the dangers of incorporating techniques and procedures into their practices if the course has not provided them with adequate clinical experience to allow them to perform it competently. And now, it is my pleasure to welcome to the Practice Perfection stage, Dr. Piero. Hello.
Oh, hello, Danny, and thanks for the opportunity. And I wanted to thank Virginia as well for this opportunity and her help in providing this webinar. And I would like to thank all of the webinar guests and people that are on this webinar, watching this webinar. I think it provides a lot of insights into how we can save some burden to all of our patients and to our families of that are our immediate families. As we know, toothbrushing has been the mainstay of dentistry for over 200 years. I have a slide later on about the history of dentistry. But dentistry, I feel, is actually hazardous to our health. As Danny was saying earlier, if you're listening, I have a book that you're entitled to free of charge. It's called Never Brush Your Teeth Again, and it has all of the information that I'm going to be talking about that's made for the layman. So this book you can give to your patients. It can help them really convert your patients to your treatment plans to make sure that they take care of their periodontal situation and prevent periodontal disease as well. So thanks very much for being here. So why do you think that we shouldn't brush our teeth? Why would a dentist, I know this is very incongruous with everything that we've learned, why would I say don't brush your teeth? Why shouldn't we brush our teeth? Well, for the very reasons that the introduction was saying, that 50% of people over 35 years old and 70% over 65 have periodontal disease. And I think by now it's crazy for us to think that the toothbrush is actually working. I don't think it's working. If it was working, then we would not have this huge statistic. The clinical trial study that I need to see would be by the entire population of for the Center for Disease Control, stating something like this would just influence me to say this is not working. So what I decided to do is find a better way to clean teeth at home. So you wouldn't get on an airplane and try to get down an airplane, and 50% of the time the airplane was going to crash. But yet we are in our practices, and we're advocating periodontal therapy, and then we hand our patients a toothbrush and thinking that they're not going to get into the same problem that they ended up with when before they started life. So we started using a toothbrush before we could walk. So it's very difficult for us to think anything differently of how to clean a tooth. And if it was working, we would have better statistics than this. So the history of the toothbrush goes way back into BC. This is with a pre-brushing, when they used to use chew sticks. And in some parts of the world, they still actually do use chew sticks. And then we could see that very early on, the first records of horsetail brushes were in the 1200 ADs. And then the first recorded use of a toothbrush itself was 1700s. Further on down the line, we had the first mass-produced toothbrush in 1780. And then later on, their first patent for a toothbrush was in 1857. But really, the toothbrush really didn't get a lot of use until 1938, when the war broke out, GIs went abroad. The government wanted to have oral hygiene importance and didn't want toothaches out in the field, so nylon was invented. And so the nylon toothbrush came about in 1938, and it was the mainstay and has been here ever since. So almost 100 years that the nylon toothbrush has been advocated as the home care product of choice. It wasn't until 1960 that we then had the electric toothbrush. But a brush is a brush is a brush. And as practitioners, we all know that toothbrush abrasion is a huge problem. A lot of patients, by the time they're 40 years old, have significant amounts of toothbrush abrasion. The toothbrush and toothpaste combination is extremely aggressive, and the mucosal tissue is damaged. You get toothbrush abrasion. Soon it doesn't get in between the tooth, below the gum line. So we have periodontal issues that are starting. Then we have a little bit of bone loss because osteoclasts are stimulated. The bone, the tissue follows the bone height, and we have more and more toothbrush abrasion. So it's not only the toothbrush that doesn't really work. just recently in 2015, the European workshop of the European Federation of Periodontology had a wonderful workshop which they do yearly. And their statement after their workshop was that there is no evidence found that the use of dental floss is effective in patients with gingivitis or periodontitis. Now, of the entire symposium, this is what their statement was on their press release, which I found very interesting. There's been other data that shows that flossing really only removes about 30% of the plaque. So what do we know about periodontal disease is that it's a systemic biofilm disease. I think that that's pretty information that's pretty standard information that everybody here listening or watching this webinar would concur with. It wasn't always thought of as a systemic disease. I think I graduated in '82, and we were talking in '82 that the biofilm was causing heart disease, and that's about the only thing that we thought that periodontal disease was associated with. And the chronic inflammation is coming from the bugs, the bioburden, the bacteria. It's usually the anaerobic species of bacteria that are hiding below the gum line and in between the teeth. These bacteria create a local immune response, as we all know, and macrophages and neutrophils pull in and move in, and these bugs invade the epithelial lining of that tissue, and the inflammation starts to release local cytokine release of IL-1, IL-6. These inflammatory markers stimulate osteoclastic activity and prostaglandin activity that will then destroy some of the bone tissue. And then, unfortunately, these markers, these inflammatory constituents, they end up signaling the liver to produce cytokines, a CRP cytokine that is a systemic cytokine that then is a marker for all of the inflammatory diseases that we see. So it's a general marker, these cytokines, and we can measure those cytokines in your office as well. You can send out to have these cytokines measured for general inflammation in someone's body, and I highly recommend that you do so. So what I'd like to talk about is, why we shouldn't brush our teeth, and I think that we shouldn't brush our teeth because really it costs so much. It costs so much to our family's wealth and health, and it creates such a burden to us, and it costs so much money. So I'd like to talk about what it costs us for this inflammation left unchecked. It's the most prevalent disease on planet Earth. There is no other disease where 50% of the people at 35 years old have, and certainly all 65-year-old people, 70% of them don't have periodontal or don't have another disease other than periodontal disease. So it's the most prevalent disease on planet Earth, and we are the guardians of that disease. So it is our responsibility to have that stewardship to manage our patients in the best possible way that we know how. And I can't think of a better way than to use Dental Air Force at home, because home care, no matter how good our work is, we can be the best prosthetic dentists out there. We can restore teeth perfectly. We can have margins that are so tight and beautiful, and the aesthetics can be so beautiful, and yet we only really can do not what God did. And so we are always compromised with anything that we do in our mouth. And I like nature. I like the way that nature built our teeth, and I like the interface of that gum tissue to a natural tooth structure, and a lot of people here recognize that too, and they'll place margins above the gum line where appropriate, and the advent of new materials have allowed us to do that aesthetically, and all that is well and good. But really, that's really shouldn't be our main concern. Our main concern should be, is this person having an inflammatory response that's going to create hardship in this person's life and in their family's life? Because one thing that happens in the family's life, whether it be Alzheimer's disease or strokes or diabetes or any of those systemic diseases that we are influencing, or our stewardship or our lack of stewardship is influencing, then we have to really pony up and be responsible for that. Then I'd like to talk about some of the studies that were done with Dental Air Force and what really Dental Air Force really is. So I think periodontal disease, most people would say that heart disease is the most costly disease on the planet, or maybe cancer. You might say cancer would be the most costly disease, or diabetes. But I say that periodontal disease is the most costly disease on earth. And here's why. Because we have this inflammatory process going on. Inflammation affects every mile of the 60,000 miles of arteries that we have. So just because we go to get bypass surgery and get stents placed for occluded arteries because of inflammation, that comes at a cost. But how this triggers our immune system is because the inflammation is really just an inflammatory issue that's responding to every mile of artery that we have. And so these arteries are becoming damaged. As the disease develops, you have high CRPs. And then you have local markers that we can read. Even in our office, we can do a blood stick and send out for what's called LP-PLA2. That's a biomarker that shows when the pimple pops, basically, because really what this inflammation is creating is acne of the arteries, is how I like to describe it. And when the pimple pops, a clot can form, and then that clot creates microvascular damage in some areas. If it's a macrovascular damage, then you have a heart attack or you have a stroke, and that's what we really see out there in emergency rooms. But it's the microvascular damage that's whittling away at all of our organs: our eyesight, our brain, our kidneys, our liver. All of those organs are being influenced by this inflammation and by the effect that this inflammation is having on our arterial system. So some of these statistics everybody has already heard before, and if you haven't, it's all in my book for the layman to be able to read too. It's really, this is going to be just a little quick guide as to all of the data. And the beauty of the book that I wrote for clinicians to pass out to their patients is really the resources that are in the book, because everything that I say in the book is backed up by clinical research, and the research area of the book is the most valuable part, I feel. So with heart disease, there's been over 500 studies that show the link, and we've all heard that you have twice the likelihood of having a heart disease with periodontal disease, and 3 times the strokes risk factors. But what does this really mean in terms of cost? It means there was an interesting study that was done by Marjorie Jeffcoat. She was the chair of University of Pennsylvania's dean of the school, and United Concordia hired her to really mine data. So they had 1.6 million people that this particular insurance company, United Concordia, is owned by a mother company. I want to say it's Humana, that purchased this dental company. So they had this huge amount of information in their database, and what Marjorie Jeffcoat did was she mined this data. And what she discovered was that the annual medical costs, they compared people who had periodontal disease and people who didn't have periodontal disease, but the periodontal treatment group was looked at in comparison to the control people who didn't have periodontal disease or had periodontal disease but didn't get it treated. And the average savings cost was $1,000 per year just for coronary artery disease if the person had periodontal disease and got it treated versus didn't get it treated.
And that's
there
annual.
Was 20 annual costs. This is ongoing every year. So they looked at that data for years, Danny.
Mm-hmm.
But it reduced. But why it reduced those costs is because of hospital admissions. There was 28.6% less hospital visits just for the coronary patient. So then they looked at cerebral vascular disease or stroke victims, and really what they got to see was that there was even bigger savings with cerebral vascular patients of $5,600 per year. These are slides from United Concordia by permission. There was 21% less hospital visits. And you can see that the costs precipitate. It goes down significantly. This is a slide showing no periodontal care to the left. This is a slide of the data that was showing of the people that had coronary artery disease and what it cost for them that when they had periodontal treatment taken care of. Remember, the ones on the very far left would be $15,000, but they didn't have periodontal therapy done. Now, we have some studies, and our studies showed that we would have twice the outcome of biomarkers and bioburden over a toothbrush. So these are hypothetical additional savings costs per year if they were to use dental air force. This is all conjectural. So this was a study that was done in the year 2013 and to 2013. And this study was done with 100 patients. There was some 50% of them were non-diabetic patients, and 50% of them were diabetic patients. And so we were looking, again, we're talking about a C-reactive protein, and C-reactive protein is made by your liver, and that's what's inflaming all of those arteries. And how that data was looked at in the prior slide, and I can go back to that, is that the toothbrush, right after periodontal therapy, you will see that the CRPs drop significantly. That's with both groups. You'll see it drop significantly on both sides of the fence. But then what happens right after 3 months after the periodontal therapy is done? You can see on the left-hand side, the toothbrush group really stopped getting any benefit from the periodontal therapy, or the periodontal therapy from a CRP point of view, from an inflammatory point of view, was mitigated quite quickly, actually. It was quickly mitigated right after the 3 months. In another someone else's study, they showed that on average, that this is backed up by other people's studies, that periodontal therapy lowers CRPs predictably, and that's about the exact predictable outcome that you would have on the right-hand side with periodontal therapy dropping CRPs. But you'll notice that on the left-hand side, the Dental Air Force group had CRPs below 1. Now, if you know about CRPs, that's kind of your goal. That's like no inflammation. When you get down below 1, you're loving it. Your arteries are looking good because you don't have that inflammatory burden any longer. Now remember, these are general markers, so this isn't an endothelial lining marker. This is just a general marker. But this is the tell on this. The tell on this is that really you'll see that it continues to whittle away at the inflammatory burden that the patient would have. So we not only at 3 months, we were significantly greater than just the toothbrush at 3 months, but it kept going after 3 more months, whereas it didn't plateau like the toothbrush group. And you'll see further that in the diabetic group, if they had an annual savings cost of $2,800, you can expect that they would have additional medical savings costs if they were using dental Air Force versus a toothbrush. So with diabetes, the United Concordia study was showing that it had $2,840 for diabetics. Earlier we talked about the cost savings of heart disease, but you had $2,800 with diabetics. 40% less hospital visits. That's huge, just for doing perio therapy. So any patients that are diabetic, hands down, they should be utilizing and making sure that there's no 4, 5, 6 millimeter pockets. You know, diabetics are have a much higher risk. It's a comorbidity factors that are involved with the diabetes. There's more periodontal disease in diabetics, and more periodontal disease exacerbates diabetes. So paying close attention to diabetes is very important, as it would be for any heart patient or any other patient really that has a pre-existing condition of a systemic disease that's inflammatory. And we now know that most diseases that are systemic are inflammatory. So there's additional savings for diabetics that was found out by the same United Concordia study of $1,477 or $1,500 savings for a diabetic, and that's just for their outpatient drugs costs. So when you add up that number and that number, you got over $5,000 worth of savings. So is periodontal therapy effective? I'd say that it is extremely effective. So what happened was I was attending a symposium at the University of Pennsylvania 2.5, 3 years back. I communicated with Dr. Jeff Cote about her study, and she found my product extremely interesting, and she said, you know, Piero, you really need to come to the symposium that's going to be at Penn. I said, oh, I'd love to, and so when I went there, I thought, well, I'm going to meet all of these periodontists. It's going to be a wonderful session. I'm going to be talking with the most influential people, on the planet there. And what I discovered was I was the only dentist there. There was actually no periodontist there either. What was there was rat PhD researchers that have spent their lives working on the molecular biochemistry that occurs with periodontal disease. It was a 3-day symposium. It started at 7 o'clock and didn't end until about 7 in the evening for 3 days straight. We had very little breaks. It was exhausting, but I'll tell you, it was the best thing that I had ever done, because what I got to see was that there are people on this planet that will literally cure cancer. They are going to grow bones and organs. And these people are so dedicated to what they do, it was just awe-inspiring to listen to these people talk. These folks were from all over the world. They published, they spoke about their unpublished data, which most researchers don't like to do, and they shared their information with everyone from around the world. There was people from every corner of our planet there. There was about 200 people. And I was awestruck. So what happened was at the very last day, the last person of the seminar, he was an endocrinologist. And so he spoke about a new drug that was going to be coming out that was going to help diabetics. And it showed a lot of promise, and it was working quite well on these rats, and was lowering HbA1cs. He says, so he gets done with his talk, and as I was flying into University of Pennsylvania, I was just getting my data in from my research, and this is what it showed. But when my data, when I was flipping through my data, literally while I was there, I noticed that we had data from HbA1c. So I had this very gifted researcher had the insight to just look at HbA1cs and diabetics. And so I want to share with you what this means, this data. At first, when I looked at this data, I said to myself, wow, Dental Air Force really hits home runs in all departments, except it really didn't help diabetics that much. I'm surprised it didn't help diabetics that much, because I would have thought that if all of these other parameters that Dental Air Force was doing so well, we're too bad, you know. That's unfortunate that we're not going to be able to help diabetics. But in the end, at the last speaker of the day, he was saying that if you have 1% decrease in your HbA1cs, that you do this. You have 16% less heart failure, 14% non-fatal myocardial infarction or heart attacks. But there's 12% fatal or non-fatal strokes, 21% diabetes-related deaths, if you can just lower your HbA1cs by 1%. You have 14% less deaths from all causes and 43% less amputations. And then 37% small blood vessel disease. That would be renal failure, eye damage, things of that nature. So when he said that, I started flipping back at my dad and said, wait a minute, I thought I wasn't doing that great with diabetics. And then I saw that really with periotherapy was able to lower this by 0.4%, which is predictable. But then the titers start to rise again because we hand them a toothbrush. And I'll show you data later about what Dental Air Force took, how it performed. So this is the medical savings cost that is, again, conjectural savings costs. And it's the reason why we are so aggressive about what we think that this can save our diabetic patients in terms of cost savings is because we had twice the outcome of periotherapy alone. So one of the things about United Concordia study, they looked at pregnant women, and we have seen this data before, some of us have, that have an average cost savings of $2,400 a month or a year. You're 7 times more likely to deliver a premature baby. This is always, this sort of information is in my book and can be distributed to your patients. Oral microbes do cross the placental barrier. There's wonderful analysis, DNA analysis, that can detect that now. About 20% of cancers are caused from chronic inflammation, and it has to do with oxygen tension. And remember, these inflammatory diseases and issues is really angiogenesis occurs, and so it starts feeding the cancers. So this is another reason why cancer spreads so fast with chronic inflammation. So if you have a pre-genetic disposition for cancers, or a pre-genetic disposition for heart disease or stroke, just the other day, this was like a few days ago, they were saying that there's a 6 times increase of Alzheimer's inflammation or decline of cognitive ability with people who have periodontal disease. I'm a little confused by this slide myself, actually, and I don't know what the 49%, I think it's 49% reduction in risk factors for kidney cancer if you were to receive periodontal therapy, actually. But your periodontal disease increases your risk by 14%. So with breast cancer, we have 11 times the risk factors of getting breast cancer with periodontal disease versus no periodontal disease. So we can clearly see that periodontal disease is one of the most costly diseases on the planet, and that's why my argument is such. Peripheral artery disease, 6 times the amount. COPD, you have 1.5 greater risk of COPD. So there's many other links of periodontal disease with all of these other systemic diseases, from psoriasis, I'll list them: pancreatitis, prostatitis, arthritis, Alzheimer's disease, colon cancer, impotence, depression. The list goes on and on. Some of them, for brevity, was pulled out of my book. My book was originally 380 pages, but editors knocked it down to about 80 pages for the layman, and for doctors to conveniently pass them out freely. So what do we do about it? Do we still hand them the toothbrush? Do we keep the status quo of 100 years or 200 years of a nylon toothbrush of 100 years, 110, 20 years? Do we just keep doing that periotherapy and then saying to the toothbrush, go get a Sonicare, go get an Oral-B? A brush is a brush is a brush, and that brush isn't going to get in between your teeth and below the gum line any better than the other brush. In fact, when I hear Sonicare go on, it sounds like a planer to me. It sounds like a wood planer. It's just a faster way of aggressively wearing out the sides of your teeth and giving you toothbrush abrasion. And there's been wonderful studies that show that you can brush your teeth for 2 minutes or 10 minutes, and it wouldn't get any cleaner than the 2 minutes. And we already know that the toothbrush isn't working at 2 minutes, so why would we think that it's going to continue to work with 10 minutes? So what do we have to do? We have to access the patient's home care. We have to change home care. We already know that periotherapy has predictable outcome of dropping HbA1cs in diabetics by 0.4%. We already know that we need to constantly go back and revisit those sites every 3 months to mitigate bleeding, to mitigate the inflammation. But then we still hand them that toothbrush. So how do we change that mentality? What do we do differently? How can we do differently? Well, we need to access those sites, and that's something that the floss and the toothbrush isn't doing. We have to break down those barriers, that biofilm barrier. It's grease. It's such a high liposaccharide deposits that it's like taking a frying pan, frying up bacon, and then throwing it under the faucet to think that you're going to remove this greasy layer with, say, like a water pick or something, and that's how we differ. Really, the biofilm needs bombardment, and so that's really what would be the most beneficial thing that we could do, is bombard the matted layer of these biofilms. We need to oxygenate those sites, because these are anaerobic species of bacteria, and these are very acidogenic bacteria. So we need to neutralize them with acids. It even goes back to the Keyes method, when he was throwing sodium bicarb and packing sodium bicarb down a rabbit hole. So I'd like to ask, how many dentists or hygienists use a ProfiJet in their office?
And that is more than a rhetorical question. Let's go ahead and use the magic of our platform here to poll our audience. We'll give you a few minutes to ask the question. Let me launch it here. There we go. So
I'm asking this because, go ahead.
Go ahead. Go ahead, Piero. Let us know why you're asking.
Well, I'm asking this because that's how this machine was developed. This device was developed, Danny.
Mm-hmm. And the options are yes, you do, or no, you don't, but you have done so in the past, or you never have. So 3 options. We are at 47% having cast their votes. We'll give another few seconds for those of you who are not accessing it by the, who are just listening in. Obviously, you're going to have to do a less than virtual vote. But let's just give it another 10 seconds to make sure everyone who can and wants to cast their vote does so. Okay, results are in. 45% don't, never did. 27% have in the past, and 27% do currently. Thank you very much for casting your votes.
Oh, thank you very much. Yes, that was very good. So half the people don't use it, and I know why they don't use it. 30 years ago, when I had a hygienist working here, I ended up wanting, of course, the best equipment, like we all do, and the ProfiJet was just coming online, and I thought that this was an interesting device, and so we purchased it for our office. And it quickly, I know why some of the people used to use it, and then no longer don't, is because it's quite messy. And remember, back in the 80s when I started coming out of school, that HIV was quite an issue, and then the ProfiJet sprays up in our face, and that hazard is spread around the office more, so it's a little cumbersome to use if it's not in the right hands. And but what it did is, for me, the ProfiJet was, what happened was, like most doctors, we didn't do hygiene, and we have a hygiene department that does that, and we really don't see what a ProfiJet does. But the hygienist is really, I feel, the most important part of the practice. And really, I don't call a hygienist someone who cleans teeth. I call them genetic manipulators. Okay, they are geneticists. They are changing the genes of their patients. They're influencing the genes of their patients by doing their work. And they are the most important part of the practice. The hygienist, unfortunately, my hygienist took a maternity leave, and I was thrown in the dental chair. And so I started to see how difficult that job actually was. And it is not an easy job. It is plaque and calculus is very tenacious, and it's a very difficult job to perform. So what happened was, I said to myself, what happened to that machine that we bought? Let's pull that out. I'd like to see how to do this job better. And so when I did, we used to have to send it in all the time to get repaired. It cost a couple $100 each time, and so I can see why people just put it on their shelves and then stop using it for many reasons. But then when I started using it, I was amazed, because what I got to see was that stain from smokers and the soft calculus and the biofilm was stripped off, just like you were taking a cursor, an eraser, and erasing it on a keyboard or on a screen. It was that effortless to do that. And I thought, my goodness, this thing is amazing. And if it really wasn't for that ProfiJet, I don't know how I would have survived the pregnancy leave by that hygienist. So then I thought to myself, this is such a device, and I created a vacuum system that would alleviate and mitigate the issue of having all of that spray around. So I designed a evacuation system that's about a 2.5 size pipe that comes literally out of the ground alongside the chair that hovers over the patient's face when I use it. And so this is a huge vacuum. A big blower is literally outside of my building that sucks this vapor out of the patient's mouth and out the entire building. So when I designed that, I thought, this would, it's too bad that we don't have this technology in our home, that every single person would benefit from this, and we really wouldn't have to have these problems in our oral hygiene if something like this was used. So that started my whole process of figuring out how do I make something like this that costs $3,000 and hooks up to another $10,000. How could I possibly get something like that at home when someone can pick up a $3 toothbrush or $2 toothbrush, and probably back in the 80s it was $1. And so my goals were high, but I persevered throughout my dental career, and I came up with Dental Air Force. So this is some of the reasons why I persevered. I knew that this device was really tenaciously going after the biofilm, and this is the most impressive slide that I ended up getting at that symposium. because what it showed me that we, oh, this wasn't it. I apologize. This has to do with the tissue attachment loss. And I was impressed by this slide as well. Of course, I thought to myself, wow, we really increase clinical attachment. That's fantastic. I don't know how else we could have gotten this. It's almost an extra millimeter of tissue attachment that we've gained by using dental air force over a toothbrush. And I thought that was fantastic, because we're down to a clinical attachment of 2.4, which isn't too bad, obviously. A gingival index is also, the bleeding was significantly different than a toothbrush, as you can see, from a diabetic and a non-diabetic. I'll leave that screen up for a little while so people can look at that. You can see that periotherapy drops bleeding immediately, but then it flattens out again, just like the CRPs. So this is following through with exactly the predictable things that you would think of when you hand someone a toothbrush. After 30 days, you have this drop because of the periotherapy. We hand them the toothbrush, it plateaus. If you look to the right from a non-diabetic patient, it's exactly the same after the 3 months. Same thing with the diabetic patient. Yet on the left-hand side, you have a gingival index of 0.7 and 0.8 with dental air force.
Could you perhaps help me understand, Piero, why the baselines differ between dental air force?
Well, this is the group. This is what the group came in at. So the groups, these were divided into groups, these 100 patients. Some were diabetic, some were not. So this is the data of the patient. So in other words, you couldn't have exactly, everybody's a different person.
I gotcha. Yeah, that's
right.
Well.
You have to look at the disparity.
Yeah.
Yeah, so you have to look at the disparity between what was done and how rapidly it dropped and that it continued to drop.
Right. The baseline is the baseline, and then you just want to see what happens from there. I gotcha. Okay.
Sure. So this was what I thought, and I still feel, is one of the most impressive outcomes of the study. When I received this, I was shocked, because really we were looking at actinomyces concomitans, we were looking at Porphyromonas gingivalis, Fusobacterium nicoleatum, that's spelled wrong, I'm sorry, Providella intermedia, and those are the pathogens that are commonly looked at in perio design studies. And what we found out was, just like the other studies, is that really periotherapy didn't do a whole hell of a lot of good for the bioburden of the patient after 3 months. I think that the other studies would show that the bioburden drops immediately, much greater than that after periotherapy. But by 3 months, those bugs are back. And other people's studies have shown that. So the bioburden comes back, within 30 days. And this is a 3-month study. So the bugs are back quickly. And that's what this is showing even at 30 days on the right-hand side of both of these cohorts of the studies. But what you got to see is that the bioburden is dropped 500% difference in PG. Now, every study that you hear about, from cancer to Alzheimer's disease, we'll talk about PG. And that's because PG interferes with the immune response. It blocks the immune response in some ways, and it lets the guard down for the fusiforms to invade, or the AA to come in, and they are commingling. So it's not just one bug. Sometimes you need both bugs. Sometimes you need, it depends on your host response. I never use the term causal, and I don't think any one of us should ever use the word causal. This is a multifactorial, multibacterial disease. It's a biofilm disease that has so many factors that are involved. I'm sure I like to describe it as when you open up the back of a airline magazine showing all the hubs and all of the connections that can be made. It looks like a mess right? It looks like all those lines are bouncing all over the place. That's what periodontal disease does, and that's why we really can't point to something and say, oh, this is causal. It's not causal. It's just associated. It's influencing all of these genes. So that's why I state that hygienists are really geneticists, that they're really just influencing, and we're nudging nature. We're nudging the bioburden, the inflammatory response. But what would you rather have in your mouth? Would you rather have 500% less PG? Or would you rather be walking around with PG tripping your genes? So what Dental Air Force did over a Toothbrush was we lowered HbA1cs by 1.04%. And going back to what that last lecture of the day on that 3-day symposium said was that if you can lower that by 1%, that you're going to mitigate those diseases like 43% less amputations. And so that was the shining light, which is the data that I thought was the most, unpromising to these individuals. Yet that was the most shining light, was the HbA1c data that came. So that significantly shows me that, yes?
Sorry to interrupt. I'm just curious. It is so remarkable that a reduction of anything of 1% can lead to such a stark improvement. In your conversations, or do you have any insights? First of all, yes. is that similar in other types of studies?
It's a logarithmic. It's a logarithmic number. That's why you see such great diversity between 0.4 and 1. That's why it's really a logarithmic number. And they are changing the way they describe that number. There's two scales that they're using actually for HbA1cs now. Although the standard scale is still being used. So they're calling people that are 6.5% basically diabetics, and you would be put on, say, metformin. And the reason why they go to 6.5 and they say that's what a non-diabetic's goal, or that's what a diabetic's goal is to get to, is to 6.5 or 7. That's because they're at a 8 or 9 or 10% to begin with, and each time they drop by 1%, they have that same impact on their life. They have less retinopathy, they have less renal failure, they have less cardiovascular disease, less strokes, less.
So 1% reduction of wherever the patient presents, a 1% reduction, whether they're super high and already suffering, they will see a marked improvement in their condition, and not just prevention, but in their condition if they already have the condition. Is that right?
Well, that is right, but even a non-diabetic, you would say, a non-diabetic, the goal would be, let's say,
prevention.
Well, prevention, but the goal would be, say, 5, Danny. If you were to ask a diabetic physician, what would you like your HbA1cs to be? They would say 5. Yet, but yet a diabetic physician would tell their diabetic patient, let's get it down to 6.5. And the reason why they use 6.5 or 7 is as the goal is because these people are so out of this, their islet cells are gone, and they need every little bit of insulin sensitivity that they have. And because they don't have that insulin sensitivity, they end up spiking their blood sugars. And HbA1cs is a marker that's attached to your sugar molecule, attaches to your hemoglobin. And your hemoglobin lasts about 3 months. So every 3 months they go and test their HbA1cs to see how well they fluctuated for that 3-month period of time. And when they fluctuated high and they spiked it high, well then that sugar attached to that hemoglobin. But that blood cell only lasts about 3 months, so that's why they go back every 3 months and read that. Is they get a better window at the look of how well did you keep that blood sugar level below 100. Okay, and so when it spikes up high, then you didn't have the insulin sensitivity from that insulin release to bring that number down. But by bringing it down, it creates huge benefits. And that's why the 1% matters so much. It's a logarithmic number, though. It matters a lot.
Yep.
It's really the shining light of dental Air Force. Dental Air Force is really a diabetic device. And the FDA allows me to word now that in conjunction with periodontal therapy on diabetic patients with good diet and exercise, dental Air Force will assist in lowering or in the control of blood sugars. That's how it has to be worded. But that's how all the drugs are worded. If you notice on advertising, they have to have that it's like a disclaimer. You know what I mean? Yep. Again, it's not causal, it's not effect. You can't say that you just I can't say dental Air Force lowers HbA1cs. I can say in one study, here's what it shows of 100 patients. You understand? It needs huge studies. It needs many studies, before Medicare pays for it. You get what I mean?
Right. But between you and me and everyone else who's listening, would you say that ceteris paribus, other things equal, that if somebody just introduced and used consistently dental Air Force, that they would see a reduction in their HbA1c?
I'll show you that. I'll share that in the slide.
All right.
Okay. So dental Air Force lowered CRPs 2.5 times over a toothbrush. And that's the culprit. The whole culprit of the inflammatory process is the CRP. And that's why we lowered HbA1cs, because we lowered CRPs. We lowered the bioburden locally. It didn't create local IL-1, IL-6 being emitted in the local environment. It didn't spike the CRPs, and so we had a 2.3 times difference in drop of CRPs over a toothbrush. And the same thing with the gingival infection, and 52% better clinical attachment loss, and 500% of the pathogens were destroyed. 5 times. There's no other device in the world that can say that. This is the only device on the planet that has ever been FDA approved to get rid of a toothbrush in the history of the FDA. And I go further in saying that really in the history of dentistry, this is the first device that ever replaces a toothbrush. But it doesn't just replace a toothbrush. It's a medical device that's going to mitigate inflammation. It's really a device. It's a diabetic device. It's a hepatic device. It's a neurological device. If it's assisting you in mitigating Alzheimer's disease and strokes and diabetes, it's a kidney. It's a device for kidney failure. It's a device that encompasses all of the inflammatory disease processes. So how do we do it? We access those sites that we were talking about. This is what the machine looks like. It's a compressor, just like that's hooked up to your dental office compressors. And it's a device that emits air, sodium bicarbonate, and it's really a delivery system. It delivers and oxygenates those anaerobic species. We encapsulate the sodium bicarb because we find that it leaches out slowly and we get more sustainability. And really what we did it for, that's what happened, but what we did it for was really to create mass. Because what we found out when we were starting to do the clinical trial studies for efficacy is that we found that plaque is a bear to remove. And so you need a lot of PSI, you need a lot of air, and you need it going fast. You need speed to it. But just because you have speed to something doesn't mean it's going to be removed. So if we used regular sodium bicarb, for instance, the mass wasn't big enough. We had to have quick efficacy. So we encapsulated it, and lo and behold, we changed the mass So the bullet at a certain speed was able to dive into the biofilm and disrupt the quorum sensing. These bugs are speaking with each other. There is a communication system, a highway system where excrement goes out that we're ingesting, which gives all new meaning to the words, eat crap and die, because that's exactly what we're doing. These bugs are influencing our genes. They're changing our entire our own biome. They're influencing our gut microbiome. And so we oxygenate, we neutralize these acids, and it's really a drug delivery system. So you could further oxygenate using hydrogen peroxide, for instance. Or you could, I purposely didn't put any sodium lauryl sulfate in it, because that's irritative to the tissue. It just is going to open up the cellular membranes of the tissue to even cause more damage and bleeding. So, and a lot of people are somewhat allergic to sodium lauryl sulfate. But sodium lauryl sulfate interferes with chlorhexidine gluconate. So if you're a chlorhexidine gluconate lover, then you could put chlorhexidine gluconate in this instead of water and use an antimicrobial or any other antimicrobial that you prefer, whether it be chlorine dioxide or, I know periodontists that use sodium hypochlorite, regular chlorine bleach diluted, and it's very effective actually. But this is a drug delivery system really, and I will go further to say that this isn't the end of it, because really what we have done is use it with probiotics. So we're fighting good bugs and bad bugs. So some of my patients, they use it. Sometimes we're trying to kill bugs, and it could be varying from week to week or even morning to night. So tonight we're going to kill bugs, or tonight we're going to grow bugs. I like to grow bugs at night, and I like to kill bugs in the morning. Or from week to week. I'll say this week I want you to kill the bugs, and next week I want you to grow the bugs. So this is really a delivery system that would influence the local microbiome in between the teeth, and we're shifting these populations of bacteria around. Now, it's a biofilm debrider. It's really a wound healer, this machine, and really what we're doing is mitigating all the bugs in the biofilm. Now, for instance, the University of Texas is investigating this machine for release or for mitigating Streptococcus mutans bacteria. But as you may have heard, or some of the people that are on this webinar may have heard, is that 70% of the leaflets of the heart are been invaded by microorganisms, oral microorganisms, Streptococcus mitis, which is the, or mutans, which is the bug that's highly acidogenic, which is responsible, along with other bugs, for dental caries. So they're now looking at streptococcal mutans mitigation with this machine, which is really, to me, it's absolutely going to shine, because we destroy all those other organisms. There's no reason to think that we're not going to lower the populations of those other biofilm bugs by 500% like we do in every other site. These cultures were taken down the rabbit hole. This is not done with just a little oral rinse to see how much bugs you have. This is paper point down the rabbit hole bugs. So we are reaching way down the rabbit hole. In fact, the FDA discussed with me being able to say that we actually remove plaque that flossing doesn't remove, because floss doesn't get down the rabbit hole. They do not allow me to say that it replaces a tooth, that it replaces flossing, because we have never gone head-to-head to floss. We've gone head-to-head with Waterpik, but again, Waterpik is a totally different device that is just shooting water, and it's literally ricocheting off of this greasy film, not oxygenating, not breaking up the barriers, not accessing the site. So if there's any questions that people have about Dental Air Force, bring them on. You can communicate with me or after this webinar, or email Danny right now.
Yeah, well, I would say immediately following, because we have no shortage of questions. But are we at the end of the presentation now?
I can discuss Dental Air Force at length, and let's take a question or two, and I can further elaborate on Dental Air Force and how it's used.
Yeah, I was wondering, because I know we wanted to ask the audience another question, and I thought that was toward the end of the presentation.
Well, I think that we have up on my screen a little slightly different presentation than you had on yours. Let's see if I have. Yes, it is.
Then I had
no, not really.
Okay.
Not really. Not really. No. Yeah, we are there, I think. Yes.
All right. Well, so why don't we go ahead and do this, because I think we'd agreed it might be useful to ask the audience if they're using oral DNA testing. So let's go ahead and launch that right now, that poll. And the question, quite simply, is, do you use oral DNA testing in your office? So please take a few moments to answer. And that will sort of set the stage for, I think, pretty exciting offer that Dr. Piero is going to be making. He's actually making 3 offers. He's already mentioned one of them. And I've read the book. It is a quick read. I congratulate your editors for dropping it from 300 to 80 pages, although I'm sure you had to, well, I don't know what you cut, but I'm guessing maybe some more clinical matters that may be, I don't know.
We discussed a lot of other links, is what we did. We discussed psoriasis, pancreatitis, prostatitis, arthritis. We did it all. You know what I mean? We hit everything with the data that was coming at us while we were writing the book, and the book took 4 or 5 years to write. But then in the end, they chopped it down to 80 pages. But I'm kind of glad they did, because really the layman doesn't really need to read it. This is an audio. There's an audio version of this book too. And so when I do send you, if you email me, I send you the book, the PDF of the book, but then I also send you the audio version, which your patients, I think, are going to like a lot better, because
that's excellent.
Yeah, I don't know if you didn't know that probably.
I did not know that, and I would love to get the audio version, so I'm going to request that as well.
Yeah, I think the electronic version is the most valuable, because I want to say that the links are very, very nice. The resources are the best thing in the book, to be perfectly honest with you, because they back up all of the information that you would be giving to your patients about, if they come in with cardiovascular disease. Man, you can go right to these studies. You can pull the studies online instantly then. Our phones are amazing now, so it's like you can just call up, okay, give me the study, and it's right there. And they could do the same. So that's why I love the the electronic version, personally.
No, I could see why. All right, the results are in.
For Italian-speaking listeners or webinar attendees, there's an Italian version too.
And then they'll be able to address you by your last name, also.
See, yeah.
Before we say arrivederci. Well, the results of the poll are in, and we've got 73% who are not doing oral DNA testing presently, and only 27% who are.
Okay, that's a significant portion. I'm pleasantly. I love to hear that even 27% of you are utilizing oral DNA,
and I have 83% voting. So. Presumably the rest are just listening in and can't vote.
Yeah, well, that's okay. It's a percentage. It's just like my data. You know what I mean? So it's So it's wonderful to hear that so many more people than just 3 or 4 years ago are using oral DNA. I think oral DNA, particularly the newer Celsius test that they have, is a wonderful test that shows you these local inflammatory markers and other endothelial lining markers, MMP, and these markers that are really giving us the tell of what to expect as far as risk factors go, and how we can mitigate those risk factors with periodontal therapy and 3-month cleanings. Most of my patients are seen every 3 months, and that's not just perio patients. I am, you talked about prevention, and I am all about prevention. I think prevention is really the key. So I have no tolerance for bleeding, and most of my patients know that. A significant part of my patients use dental air force. I have patients coming from all over the place. I'm so always in awe when they show up at my place and I read where they're from. I'm amazed. It's really encourages me to keep putting it out there for not just the clinicians, but for patients themselves as well, because people are starving to learn. Yes.
Yep, indeed. All right, now we have a number of questions, a large number of questions. Let's dive in, well, because we only have a few minutes. First question, and I would ask you to keep your responses relatively brief so we can get to more questions. The first question is, how is your system different? Well, if they were paying attention, I think this one's been answered, but let's go to it anyway. How is your system different from a water pick?
Well, water pick uses just water. And we use, it doesn't oxygenate. It doesn't. It ricochets right off of the biofilm. It doesn't have equivalency to even floss, because if they could have, they would have. There's been many studies, and the FDA has not granted to them that. In fact, that's one of the reasons why they won't grant me that, because we went up against Waterpik thinking that they had that, and they didn't. But the Waterpik doesn't oxygenate. It doesn't bombard the biofilm. You need to salt and pepper that. You need to literally put bullets into the biofilm to start the form sensing, and it doesn't brush your teeth. It doesn't clean your teeth like a toothbrush would either. It's the sites in between your teeth. So it's vastly different than a toothbrush. It's vastly different than
that's why your product is so aptly named. I think it says it all. And this question, I think, was just answered. You also answered this, which is how the book is best used. It's basically as an education tool for patients. Would you want to elaborate any on that?
Yeah, that's what I would like it to be used as. It's a bold statement to make, and I know that some dentists it's incongruous with their thinking. But I think that if you listen to this webinar and you are on the same page as the current thoughts of systemic disease healthcare practitioners and oral physicians that we are, then we know that we have to change that our mode of thinking. And so really, you're a marketing man yourself. This book was named so that I can get publicity using this sort of like a head turner. What is that? As a dentist talking about no brushing your teeth. But I would like to say that the people are listening here, they can also get local publicity by utilizing this system, being on the cutting edge of something that the guy down the street that's doing mediocrity dentistry is really you're leagues ahead. And so what I found is that those people end up, and we will help them if they'd like, is to get local publicity for utilizing and being involved with this sort of technology. So
that's an excellent point, Piero. Yeah. And I will be happy to help too. But I just underscore it. This will differentiate your practice, and it's a the media like controversy, and they do pick up on sound bites and headlines that turn heads, just as Piero said. Excellent point. Does your system help remineralize teeth?
Well, it has, interesting you asked that. It has a component of tricalcium phosphate. So we do what all toothpaste do, and your saliva has calcium triphosphate in it as well, and so we increase the concentration of tricalcium phosphate as well in the product. And so we have no clinical trial studies that show that we are adding tooth structure to a tooth. I'm a little, I think that without any, you could use zero. I mean, we are all putting enamelgenesis to a tooth and deposition. and it's happening every day, all day long. We are adding it usually at night, and we are diminishing it usually during the day, during our acidogenic processes. So this is an ongoing event, but unfortunately we have more destruction than we have apposition. So it would lend to reason to know that if you got rid of the acidogenic component, then other studies have shown that when you can increase pH, you are tending toward apposition of enamelgenesis.
Okay.
Good question.
And, well, let's just really quickly go over, somebody asked about the pricing. I think you had that, and you know what, let's jump in. Explain the offer for people to try the system themselves and how you can even offer it to them for no cost if they're going to participate in your case study.
Sure. The unit retails for about $600. That we have a few things that you could add on to it. For instance, this can be used in the shower, and I highly recommend people using this in the shower because then you don't need the learning curve, because like a ProfiJet, this can be, this is a big machine. This is an expensive machine at $600. I'm not saying that it's not, but I think that the value that you get out of it is tens and could be hundreds folds of this product. And it's really the value that you get for it. It's not just the savings of tooth. I spoke the other day to diabetic folks, and they said, well, you haven't mentioned the benefits to teeth. And I says, well, I'll have a patient come sometime to the chair, and they need a root canal, post-core, and a crown for $2,500, and they say, take the tooth out. So patients aren't as interested in taking care of their teeth as they are preventing Alzheimer's disease. So obviously, this is a great product to preserve your own dental, work, and our own work. We want to preserve it as the acidic bath that we're putting our dental work into is destroying our work. So by utilizing this machine, you're actually preserving your work, and why wouldn't you want to preserve your work? If you had a Ferrari, you'd want to keep it clean, and that's exactly what this machine does. So the price of it is $600, and we offer it as a professional pricing at $400. So you have about a 50% markup on the product, or 33% increase in the cost to it. So yeah, you can make a couple $100 on these. This is not like a drug that you would have in your office that would be administered or prescribed, and then there'd be some sort of a problem with prescribing it, because really you would do the same thing with a Sonicare, say, or any other device that you're using for your home care that you may be recommending to your patients. It's really about the education, and I highly recommend that your hygiene department really goes over with them. You can have one of these in your office and then show people how to use it. And that's really what you're getting paid for the $200 that you're utilizing. But you get to do that outside the dental chair. So the dental chair cash flow is, from a financial point of view, this is a money earner for practices. And it's a money earner because people are going to start talking about it. Their other relatives and their neighbors, they're going to hear about this machine. I can tell you that.
Right.
Because that's
especially when they compare stories with their friends and relatives that paid $2,000, $3,000 for radical scaling and root planing, and they avoided that. So.
Well, it's not to avoid that, though. It's not to avoid that. So when a patient comes in, that's not my function. I recommend a lot of these products. I don't want dentists to feel threatened by this product at all. I want this to be an adjunct to the best type of dentistry that they can do, actually. My dental Air Force users still come in every 3 months. It's about how clean can we get these mouths, and how far down can we drop this bioburden. So it's not really to cannibalize on their practice at all. It's to enhance.
I guess I meant to mention surgery, but does this not is not part of the benefit the avoidance of the necessity of surgical intervention?
Well, if you were preventing disease, but this is the only product that we can now say instead, a toothbrush and other devices out there, they are always, if you notice their advertising, is for the prevention of gingivitis, and that's why the European Federation said that the toothbrush doesn't treat gingivitis or periodontitis, because once they have it, the floss is doing no good whatsoever. And the reason why they end up getting it is because it's just it's not in use device. But when we use a dental air force, it's a totally different experience. So that it's a totally different way of looking at how to manage your patients. Is how I like to think about it. It's about prevention. If you could prevent the periodontal disease, and you can, then you're going to prevent the surgery. So I hope that answers your question.
It does. Thank you. As far as the case study, we'll be sending an email to everyone explaining how you can inquire and see if your practice qualifies to receive a dental air force unit without any cost, just simply by agreeing to participate in the study. So that's all the time we have. We have about 7 more questions. What I will do is share them with Piero, who will then respond individually offline to each of you who asked the question, and thank you very much for submitting those. And at this point, I just want to thank you again, Piero, for sharing your views on your amazing invention, the obvious passion that you have for it, and the motivation to really help get this country healthy by this promise that it holds for preventing so many of the world's ailments, as well as for your generous offer for attendees to receive your book for free, and especially to help contribute to your prevention movement by allowing people to own the unit and to participate in this clinical study.
Yeah, there's a simple case. Go ahead. I was
I'm just wrapping things up, but go ahead. Sure, if you want to make a closing remark, please do.
Yeah, I do. I want to talk about this, just briefly about this case. It's really a case study, not a full-blown clinical trial study that I'd like some people listening or online to engage themselves in, because again, I think that if they did, they would get a big kudos from a marketing point of view if they got themselves involved with this. Just doing a simple case study will bring legs to your practice.
Excellent. All right. In a few days, you will receive an email with instructions on how to receive your 1.5 hours of CE credit, as well as to take advantage of Dr. Piero's offers. I want now to invite you to mark your calendars for our next virtual training session, which will be on Thursday, April 28th at 6:30 p.m. Central Time, when our presentation will be entitled, "Put Your Patients to Work for Your Practice. Patient ambassadors are your best marketing tool." I will be sharing a guaranteed 9-step process for generating a steady stream of high-quality patient testimonial videos, as well as techniques for generating 5-star patient reviews, both of which are among the simplest and most powerful ways to attract new patients. It really is. Until then, this is Danny Bobrow, with special thanks once again to you, Piero, and to all of you for your continued commitment to practice perfection. Goodbye, everybody.
Thank you. Very good. Thank you, everybody.
You're welcome. My pleasure. Thank you.